I'm going to finish up the day. We're going to do chapter 20, page 231, wrist, hand, finger potpourri. And it's not nearly as heady stuff as what Jerry was doing. And part of the reason we let Jerry go when he's talking about that is there's really very few people who know the ACS and stroke literature the way Jerry does it. So when he's talking about something important like that and reviewing glycoprotein inhibitors and heparin, you just can't find access to someone who really knows that literature like that. I just couldn't bear to stop him. Usually can't. So we will close this down and get through this pretty quickly. The first paper is a fascinating paper. It's a hand surgeon diatribe. When you read it, you'll be thinking he's a little bit like me. He needs some Haldol. Basically, he just points out that finger injuries are mismanaged by emergency physicians miserably. And he wasn't happy with anything. The splints were too long. They were too short. They did the wrong thing with the nail. And it goes on. It's one of those papers, when you read it, you remember being a third-year medical student, in an operating room with a surgeon, where the smarmy thing to say to the surgeon when you were that medical student was, how would you like me to cut the knots, too long or too short? Because you knew you were never going to cut them just right. And this is one of those. In the bigger picture, though, this hand surgeon has something that's worth remembering, which is that 85% of a hand surgeon's work is repairing something that's already been managed, or if you will, mismanaged once before. So really, in their experience, they don't see any of the stuff we do right. They don't go to them. They only see the stuff that isn't going well and was probably more complicated to begin with. So they see a selected thing. And it is worth remembering that 85% of their work is fixing something that was already managed poorly to start with. And that's important to know, that there's some humility required when you're seeing these things, and there's lots of stuff to get wrong. The hand is a complex thing. I mean, it reflects lots and lots of, millions of years of evolution, or very intelligent design, if you prefer. So that's kind of the framework to remind you that if you have hand and finger injuries that look like they're beyond you, don't hesitate to refer. The problem is finding them for your people, given their insurance status. All right, the next couple of papers talk about the next big medical legal quagmire here. We all know that scaphoid fractures do poorly. We all know you can miss them. We all know you need to be clinically sensitive to them, that there's some exam tricks. Abstract 2 talks about scaphoid fractures and looks at how good is the inter-rater reliability, the kappa value for reading these views, 4-view scaphoid series or a 6-view scaphoid series. And they compared an ER doc to a radiologist to a hand surgeon. There were 4 doctors altogether across those 3 specialties. And they found that the doctors agreed that there was a scaphoid fracture on 2 of 35 that were present. Inter-rater reliability quite low. In other words, there's a lot of, the x-rays are not very good and the inter-rater reliability is not there. The people who write this article are people who are in favor of MRI. So you know what they're going to say. They're going to say, of course, MRI is the gold standard for scaphoid fracture. I don't think we're there yet. There are a lot of other ways. What are your choices? You could CT them, you could MR them, you could, imagine this, splint them and re-examine them in a week. Imagine that. That's what they do in Canada. That's just way too rational. To protect it if you clinically suspected it with negative x-rays and re-examine it. Now, if you're wondering, how does MR come into this? Many of you remember the days that the reason you did acute CTs of the head was CT was better for bone and blood. Suddenly, MR is better for bone? Can that be right? Yes, MR actually is not a static technique, and if you want to hang out with a radiologist, you want to rent a big black Mercedes-Benz and hang out with them at some expensive club, you could do so, and what you would find is that the new term that they're using is to stir it. Short tau inversion recovery, MRI, is actually quite good at bone. It's good at subtle bone pathology like stress fractures and other things. And so it turns out that MR, as it has evolved with its different techniques, short tau inversion recovery makes MR superior to plain films and probably to CT for bony pathology. Does that mean you need to MR your scaphoids? No, I think you need to know the clinical maneuvers. Snuff box tenderness. Remember, slightly flexed and ulnarly deviated so that you have optimal chance. Axial compression. And then if you're in Britain or in Europe, they like scaphoid tubercle tenderness, which is at the base of the thenar eminence. If you we're trying to put your pinky through the snuff box from the back side, tenderness right there. And this paper forgets one other thing. They lead out the exam. And one of the things that our radiology colleagues are a little bit uncomfortable, particularly with extremity films, maybe not so true with heads and bellies and chests, But with regards to extremity films, and I'm always telling the residents this, exam plus x-ray is greater than x-ray, no matter how much you know about x-ray. So the idea that you would defer to a radiologist who hasn't examined the person for your extremity films when you have and know where they hurt is just something you shouldn't do. They don't know where you're looking. You know, extremities are quite examinable. Abstract 3 looks at the 6-view carpal row. Are 6 views to look for scaphoid better than 4 views? Yeah, they're a little bit better, but you're still going to get some that are wrong. So 6 views still is going to have false negatives, where you don't see a fracture and one is present. The scaphoid is tricky. And why is the scaphoid a problem? Well, the problem with the scaphoid is that if it does die, remember it's got the retrograde flow of blood, and so you get avascular necrosis with a post-traumatic arthritis that affects the largest articular surface area in your wrist. And so you're going to get post-traumatic arthritis. It's bad. Some of these papers ask the question about should you see someone, they're tender, the x-rays are negative, what should you do about that? Splint them, got it, with a thumb spica splint. Short arm or long arm? Well, a couple papers asked this, and I think the literature is pretty clear on this, that from the ER standpoint or from a clinic standpoint, they should be placed in a long arm thumb spica. Pronation and supination produces movement at the scapho-radial junction, quite a bit. Abstract 4 says if you put them in a short arm, there's increase in delayed union and an increase in non-union. That's good enough for me right there alone. Abstract 5 says short arm doesn't immobilize the fracture. This is a cadaver study where they looked at what supination and pronation does, produce displacements of 1 to 2 millimeter at a broken scaphoid. Not good. And abstract 6 says that slight palmar flexion also closes the fracture gap too. So if you're going to thumb arm spike them, you'd put them a little bit this way, in a long arm. And that would be the best outcome. Neutral position is not as good as slight palmar flexion. And they noticed that if you allow supination and pronation in that study, in other words, the short arm, that it unlocks the scaphoid. And what you'd like to do is have the scaphoid locked between the trapezium and radius to promote healing. Unlocking it, which pronation and supination does, is bad. And you basically unlock the scaphoid if you put them in a short arm thumb spica. They should be in a long arm thumb spica splint until they're reevaluated. Yes?
Yeah, well, you can't see the fracture in the first place. Does it suggest that it's a stable fracture?
No, that's not true. Remember, because the blood supply comes retrograde, a waist fracture, it's not whether it's stable, it's that the waist fracture interrupts blood supply to the proximal portion of the scaphoid, which is in its distal circulatory bed. And so since these can have bad outcomes, and we know that, then the bad outcomes may occur regardless of what you do. But you don't want someone afterwards saying the bad outcome was because you inadequately mobilized it. So since we know this is an area fraught with bad outcome, the treatment ought to be maximal, and we have hard evidence that short-arm immobilization strategies aren't optimal. 4, 5, and 6, 3 papers, so all saying the same thing. So they should be in long arm thumb spicas because we know some of them are going to have bad outcomes even when you do everything you can right. And so I think the evidence is pretty clear on this based on those, and there are other papers that talk about it. This is one of the #1 causes of lawsuits against people who work in urgent cares and emergency medicines because the outcomes are so bad. And so you don't want anyone to point at your care and say you didn't do everything you could to make it best. And when it's just the length of the splint, why would you, what's the beef? Well, if it's just the length of the splint.
You don't mean above the elbow?
Yes, I do. Long arm, above the elbow. If you don't include anything that spares the elbow allows them to pronate and supinate. It's only when you go above the elbow that they can't pronate and supinate. So it's a long arm above the elbow immobilization is what all of these papers suggest is the optimal way to immobilize these. As long as you make it so that they can't supinate and pronate, that's fine. If you sugar tongue it and it ends here, they can supinate and pronate. If you go past the elbow, then you're there. Abstract 7, we're changing topics, moves to Quervains. Quervains tenosynovitis, kind of a fun disease. First, extensor compartment. Finkelstein's test. It's one of the work-related cumulative trauma. Some of you work in Occ-Med, you will see this. After carpal tunnel, it's the second most common one. And there's some papers that talk about what's the best thing to do. Should you inject them and splint them? Should you inject them and mobilize them? Does the splinting help this? Abstract 7 says, the best overall was just to inject them, steroids, and give them some NSAIDs, and then not splint them. Let them mobilize a little bit, and might be better for them. And so that's one thing to talk about there. By the way, most of these, the issue is restricting them from the activity that caused the problem. Some people put them on systemic steroids. The literature is a mess with regards to that. This is an inflammatory condition, and so NSAIDs do appear to help and should be used. And some of them have enough pain that they might need something like Vicodin as well for a short course, 3 to 5 days, while it cools off. Ganglion cysts. Abstracts 8 and 9 deal with ganglion cysts. You know, someone comes in with a big ganglion cyst on the back of their hand. What can you do about that? We know that if they're going to have surgery on this ganglion cyst, that they have to take out the whole encasement in the shell, and it's a pretty big deal. Does simple aspiration, if you numb up the skin, put an 18 gauge, and it takes at least an 18 gauge because it's like a jello in there, right? It's like a jelly. You got to kind of express the jelly and get all that jelly out. Does that work? Aspiration. It turns out that simple aspiration works pretty well. Some of them will recur, but simple aspiration is successful on the first try about 50 to 60% of the time. By the second try, about 75% of the time, and the third try, about 80% of the time, and you'll have saved the person a surgery. So that's what Abstract 9 says. Abstract 18 says don't put steroids in there. You know how you sometimes they'll put steroids in, like we talked about olecranon bursitis, because there's an inflammatory component? That might help there. In a ganglion cyst, you actually want inflammation there. You want the thing to adhese down. When I was taught to do it, although there's no literature on this and I've looked for it, I was taught by an orthopod, aspirate the jello and irrigate it with hydrogen peroxide to increase the inflammation so it would adhese down, so that the capsule would be there and it would be readhesed. So steroids don't work. That's what 8 says. And for those of you who are, work in a managed care situation, be careful. Patients are very pissed off at their managed care when they have these. There was a well-documented, it was in the newspaper, story where a memo was found from one managed care executive to another within, and I forget which managed care organization it was. It doesn't matter. It could have been any of them, where they indicated what their strategy for a ganglion cyst was, which was to keep promising referral and delay for about 2 years, because they know that most employed people change their MCO on average about every 24 to 28 months. So that if you could delay for 24 to 28 months, the person would change their MCO, and now the surgical burden would be the next MCO's loss, and by delaying it, you would have increased the profits of your MCO. So there you go. That's what it says. Trigger fingers. What should you do about those? This is a paper that says we are often nervous. Remember, it's a trigger finger is an inflamed tendon catching at the A or C pulley, and it locks. And so, the question is, does the injection of steroids have to be exactly into the sheath, which is why a lot of primary care and ER docs are pretty hesitant to inject triggers. I personally am a little bit hesitant to do so. This is a paper where they added contrast to see where it is and asked, are trigger fingers, does it have to be exactly in the right place, or is sort of nearby good enough? And what they found out actually is that trigger fingers are sort of like horseshoes and hand grenades. Nearby is good enough. And so it doesn't actually have to be in. In fact, when they were sub-Q near the A1 pulley, not in the tendon sheath and not at the A1 pulley, when they were just sort of in the area, the outcomes were best. So this paper suggests that if you want to try injecting, and I personally still don't do them, but if you want to inject trigger fingers, that this concept that you have to be exactly at the tendon sheath and get it just right, and that complex and anatomic knowledge is required, this paper would say, nope, you can be kind of nearby. It's a small study, 107 people, but says, go ahead and do it. X-raying fingers, a couple papers on this, 11 and 12. They both say that you can't really just get away without doing obliques. There were some papers that said just an AP and a lateral is good enough. You don't really need the obliques. And people have argued about this. But Abstract 11 says that 7% of the fractures were only seen on the obliques, 1 in 15. I'm not getting rid of the obliques, especially when you keep it in the setting of the first paper where they're talking about us mismanaging and misidentifying injuries. Abstract 13 says that you might even add another oblique, that most of the obliques that we get are externally rotated obliques, and that sometimes if you add an internally rotated oblique, you'll pick up new pathology. And so 12 recommends that. And so if you really think the person's finger is injured and you didn't see it on the first set of x-rays you got, AP lateral and the usual oblique, you might get an internally rotated oblique in addition. So we're not ready to ditch the obliques. In fact, more obliques might be what you need. Boxer's fractures, a bunch of papers here. If it's in Europe and you got a boxer's fracture, what do they say to do? Nothing. They say put an ACE wrap, send them back to work. The only thing that matters is if it's rotated. So in the United States, we say 10 degrees of angulation, 20, 30, 40 is acceptable. In Canada, they say 10, 10, 20, 30. They're a little more conservative. And in the United States, when people have these and they're more than 40 degrees, we put them in an ulnar gutter splint and we reduce them and push on them. Does that work? No. They don't stay. And so we have abstract 13, says pain meds and early rehab. Give them a sling for 48 hours and tell them to go there if the angle was less than 30 degrees. Do almost nothing. They'll be fine. Dutch paper, abstract 14, says functional taping works better than plaster. Just tape it to the next one. What happens, by the way, if the angulation isn't reduced to these people? They get what's called extensor lag, which means that they have to learn to extend their finger more aggressively than before. And will they learn when they have extensor lag? Yes, they learn pretty quickly. In fact, one of the things that, if you work in a big teaching hospital, you see some of these bad things where someone has a big laceration across their forearm, bunch of extensors out, you hook them all together, you got a tourniquet up, you're in there for an hour and 45 minutes repairing these extensor tendon lacerations in zone 8, which is a very repairable thing to do. And you get all done with them and you tell the person, well, give me the finger, and they go like this. And you go, oopsie, might have hooked the wrong one to the wrong one. And so I've actually seen that happen a couple of times, and the question is, well, what do? Do you reopen the thing and reattach them and take it apart and put the right ones together? No, you just leave them. They'll relearn the motor programming very quickly. And so the same with extensor lag, they relearn the programming quite quickly. Transthecal block, nice way to get a finger numb. Abstract 16 describes it. I don't think it's that, getting a finger numb with a digital block is not that hard. This says a transthecal block is easier, and you can look at the technique if you want to know it. Abstract 17, 18, 19, and 20 ask the question, you used epi, lidocaine with epi, right? You were doing your procedure, and you looked up, and you went, oh, I got the red jar. I meant to have the blue jar, I got the red jar. I was doing this finger procedure using the lidocaine with epi. Is it a crisis? And they all say no. Abstract 17 from Dalhousie says, not really a bad problem. Abstract 18 is a Brit paper, says no biggie. Abstract 19 refutes the dogma. Abstract 20 is a UCSF comprehensive review that says it's not a big deal. Abstract 21 says when it's really bad, and look at the paper 21, it's kind of funny. Abstract 21 is where a guy put an EpiPen into his fingertip by mistake. So that's a pretty good bolus of epinephrine right to the distal bed. And the guy had profound vasoconstriction, had an ischemic finger, and if that were to develop, they said, okay, just do a digital block with phentolamine. That's what they did. They put an alpha blocker in there, 0.5 milligrams and 1 ml, put up a digital block, and his finger recovered. So this reminds you that using epi is it's not a disaster if you do so. In fact, some of the papers recommend it if you got a heavily bleeding finger that you need to repair. You could put a little low-dose epi in there and it'd be fine. So this whole concept, and by the way, how you learned, what is it, ears, nose, fingertips, and toes, and then they add, and penis, don't use epi. The ENT doctors who put up auricular blocks, right, they a V of lidocaine with epi there and a V, they use epi all the time, the ENT people do, on their auricular blocks, have no problem. So this is largely a myth that the epinephrine is going to cause stuff to fall off. Should you avoid it? Probably routinely you should avoid epi. If you have a really actively bleeding finger and you want to get a better look at it and you're trying to clean it up, you might actually use a little epi and be fine. Digital tourniquets, abstract 22, quick paper, says if you just use a surgical glove and tie that around as your digital tourniquet, that might be too tight. It might injure things. It says that the pressures from a surgical glove can get to be greater than 1,000 millimeters. Recommended pressures are around 300, 3 to 350, and so 1,000 is too high. A Penrose drain works better because the Penrose drain keeps a broad pressure area, but the glove tends to roll up and get tight like a band, like a string. So the surgical glove cheapo technique, wrapping it around the finger, bad idea. Partial tendon injuries. Abstract 3 deals with flexors, but the same is true. You explore a wound, you find a partial flexor or a partial extensor tendon injury, what should you do? If it's less than 75% of the territory of the tendon, you should do nothing. repairing it, throwing some Merceline or some long-lasting thread in there, increases the likelihood of adhesions and complications. So you should splint them for certain so they don't stress that tendon, but it'll probably heal better if you do nothing. And that's important. Nail trephination issues, we got a couple papers on this. When should you release the blood from a subungual hematoma? Some people say you don't need to do it if it's less than 50%, just leave it alone. My feeling on this is I just ask the patient if they can tell what their pulse is. If they can tell me what their pulse is, hum, pum, pum, they can feel it, then releasing a few drops of blood from that will make them feel a lot better, and I think it should be done. And you can do it with the red hot nail trephinator, or you can use it by spinning an 18-gauge needle. I actually like spinning the 18-gauge needle. Just the little shavings of nail come out. Just spin it back and forth. It doesn't hurt at all. Just spin it back and forth gently. They start coming out. Then you clip the tip of the nail off, the tip of the 18 gauge off with your trauma scissors, so it's a little shallower. Spin it a little more. It takes about 3 minutes. Drop of blood starts forming. You're done. Much easier than the red. I know a story of someone who tried to use the red hot nail trephinator. They had this patient who was having problems with the pain control. They said, "Well, do you want a digital block?" The patient said no. They said, "All right, well, I'll spray this ethylene chloride on it." Spray, 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 spray. The fingertip turned white. They plunged the red hot nail trephinator into it, and the whole thing blew up because it's flammable. And so that patient, I saw that patient later for a facial laceration. They were trying to get me to testify against the other doctor because she claimed that she had a brachial plexopathy from pulling away from the explosion. I tried to tell her with a straight face that it was the standard of care to blow those up. That way they're sterile. Really, no, we like a major explosion for all of those. Anyway, so there's some papers on that. Open finger fractures, what should you do about them? 28 is a nuts paper, says, I don't think antibiotics help. And they may not help that much. I think wound care is more important, but we know that the more distal a laceration is, the more likely it is to get infected. We know that bone doesn't have excellent perfusion, and tendon more likely to get infected. And so I don't see papers like 28 that's saying that antibiotics don't help, and 27 says the same thing. I don't see them changing practice. They're in there for you to look at if you want to look at it, but I don't see them changing practice. And by the way, they're pretty small studies. They're not big enough. I would need some large study to, we talk about this a lot in this course, that one paper doesn't change practice. And in this kind of situation where you're going against the grain, 2 small papers don't change practice either. And then amputation, near amp care, we got 8 papers here. What do they say? They say, don't get too wrapped up in this. The big things to remember are if they're young, if they're under 5 or 6 years of age, they're salamanders. It will grow back. Just clean it up, debride it, and let it grow back. If they're an adult and there's exposed bone from the distal phalanx, it probably should be rondured back. You'd like at least 2 millimeters to 3 millimeters of tissue to cover that. If you have to rondure it back to do so, then you're going to need to do that or refer it to a hand surgeon who can do it. To cover exposed bone with just skin and say, I think it'll heal, it's not enough tissue. You want 2 to 3 millimeters of tissue over it. They say that the sensation will come back, but it will take months. They say that they will take about a month to heal, and that the biggest obstruction to healing is repeat dressings. That you should just load this thing up with Silvadene or polysporin in a non-adherent Xeroform and put a big thing on there. And you should tell the patient that even if there's a little purulent drainage, that dressing shouldn't be changed for at least 4 or 5 days. Leave it on there. It's the taking off and redressing. You keep pulling all the granulation tissue off when you do that. So leave the dressing on. And your first wound check, a lot of these papers say should certainly not be before 72 hours. And some of them suggest it shouldn't be for a week. Give it a chance to heal underneath there with all that non-adherent junk on top of it. And abstract 29 in particular says, remind patients that the outcomes are not great, but they're not better by spending a lot of time going to the OR and revising them. That, it will heal. It's going to take a long time. You have to be really gentle with it. It needs to be promoted. Abstract 30 says conservative manage better. Abstract 31 says non-surgical approach. Abstract 32 says minimize your alterations. Just get skin coverage and tissue coverage if there's exposed bone. Abstract 33 says if you got a rongeur, rongeur. Abstract 34 says OBSOT dressings. Do not change dressing except Q week. And before you change the dressing, soak it for a long time so you're not debriding at the time you're changing dressings. Abstract 35 and 36 says Silvadene works. So that's a common thing to be involved with. It's an area there that just reminds us that less is more. And I think this evidence, the evidence that's offered up there, tells you a lot about how to manage these partial amps, near amps, avulsion type injuries of fingertips. If you have a hand surgeon, you're the patient's well insured, I have no problem referring this whole ball of wax to them. The problem is many of us don't have one, and so you're left sort of doing it. And these papers all suggest that your conservative management will work pretty well.